for all you social drinkers and social smokers, you know, that combination can put, and I guess I shouldn't have said you, but that implies you. But for social drinkers, social smokers, you know, that combination can also increase your likelihood. Yes, sir.
I was saying, for the alcohol use, does it matter versus someone who drinks like a glass of wine a night versus someone who drinks like a 6-pack a night?
So the likelihood that someone who has kind of a 1 to 2 drink over a long period of time, if you're just using alcohol, that develops pancreatitis is low. But it's when you add on an additional risk factor. So someone who may now add on and you know, may start a new medication. We'll talk about medications who add something new. Even if they're in that acceptable range, the ADA recommended, you know, 1 to 2 drinks, man or woman, for a chronic period of time. If you add anything new, sometimes that can be your tipping point. If you have someone who drinks higher amounts of alcohol for longer periods of time, obviously they're at a higher risk. But again, the guidelines, when you look at them, they don't separate. So typically what we're talking about is people who are abusing alcohol for either a short period of time or for people who abuse alcohol to higher above recommended levels for longer periods of time and have some sort of change in their diet or change in their medication or something else. But chronic alcoholism, even at normal levels as you age, can put you at an increased risk too. We can have procedure-induced, so we can have these retrograde cholangio processes, which you guys won't be doing, but you can have these procedures where someone has stones. They go and they do an ERCP to remove the stones, as we talked about with cholecystitis or cholangitis. You can develop pancreatitis after that. But so the big things are going to be the alcohol, the drug-induced, which makes up a small percentage, but is a big area where pharmacists can have a lot of hand in terms of trying to identify drugs, making appropriate recommendations, and then hypertriglyceridemia. So we can see hypertriglyceridemia goes hand in hand with alcoholism, but we can also see it in patients who have diabetes. You can also see it as a drug-induced hypertriglyceridemia. So generally what you're talking about is triglycerides above the threshold of 1,000 is what the cutoff typically is. Do you guys recall or know the drug most likely to induce hypertriglyceridemia? You talked about it in sepsis, hopefully. I would imagine you did. Propofol? No, you didn't talk about it? You didn't talk about propofol, or you didn't talk about hypertriglyceridemia with propofol? You didn't talk about propofol at all? So propofol is a drug that you can use as a sedative in patients who are intubated, and it carries with a high emulsion, a high lipid emulsion component. So it looks milky white because it has a high fat content, and so propofol can induce triglycerides. So for any of you guys who see a patient who's intubated, sedated, who's on propofol, you have to be careful about the dose limits for a variety of reasons. You can have propofol infusion syndrome, but you can also have hypertriglyceridemia. So it's another concern in patients who are on TPN, who may be getting supplemental lipid emulsion. So you can have high levels of lipid emulsion that can cause hypertriglyceridemia. That's generally the acute. Typically what you see is people who undergo massive amounts of alcohol or higher than normal amounts of alcohol, but also some of these others. Chronic pancreatitis is people who have had acute pancreatitis, largely. They don't stop whatever the activity is or the medication is. So people who have acute pancreatitis because of alcohol and don't stop drinking, they will repeat and have chronic. People who have some idiopathic concerns are lower, so they may have they may have some unknown reason, hence idiopathic, but they may have some reason we can't identify. Some people who will have it based on medications that don't go noticed or picked up. And we have a number of different criteria based on patients. I've taken them out in terms of the diagnostic criteria, but you can't necessarily say for chronic. If it's outside of alcohol, there's a variety of different reasons, but most of the reasons, unfortunately, with chronic pancreatitis tend to be alcohol-induced for people who just don't stop or who for relapse for one reason or another. So because we're pharmacists, soon to be pharmacists, we're going to focus on drug-induced pancreatitis, but realizing that that makes up a small portion of the disease. Why is it important? Because this is something that you can have a huge impact on. I've had students who have identified drug-induced pancreatitis. I've had myself and other colleagues who have identified it. You don't see it very often, but you don't want to miss it because it's a big area. This is review based on the categorization of the likelihood of the drug or drugs to induce pancreatitis. So there are 5 criteria. There's a 1A, a 1B, a 2, a 3, and a 4. Largely, that is based on the amount of evidence that has been published and made available that this drug or drug class can produce pancreatitis. So, am I going to test you specifically on the differences between 1A and 1B? No, I don't. You know, it's like the literature in drug information. There's variety of strengths of literature. Obviously, the higher the number, the more case reports, the more well documented this is in the literature. But this will be important when we talk about drugs and their likelihood to cause pancreatitis. So how does drug-induced AP, acute pancreatitis, happen? Generally, you have some sort of cytotoxic effect, so you have direct inflammation and an insult to the pancreas. You have metabolic changes in terms of your ability to form appropriate ACE and R cell function and endocrine exocrine function. You can have toxic metabolites which can form, so some drugs like with statin therapy will directly cause toxins. When we have hypersensitivity reactions, so you can actually have angioedema with ACE inhibitors or ARBs that's localized to the pancreatic ducts. So when we think about angioedema with ACE inhibitors or ARBs, you think about facial angioedema, but you can have localized pancreatic angioedema, which is a much more rare presentation. And then you can have other adverse drug effects, so like things with propofol, which you are all now acutely aware of. Oral contraceptives and diuretics can cause hypertriglyceridemia, so if you recall back to your diuretic lectures, things like diuretics or